right, guys, we're on to the third video. We've only got one more after this. So this one we're going to talk through the cancer treatment team. So we've kind of discussed a little bit about who you would refer to when so far. But by the end of this presentation, you should be able to recognize some of the flags or warning signs of when you would want to refer to certain clinicians and specialists. Alrighty, so the oncologist is kind of the main team leader and driving force in the cancer patient's treatment team. So often the main referrer to other specialists, but we also have to remember they have a very hectic caseload. Um, so there are different types of oncologists, so medical, radiation, and surgical, which all have their own areas of expertise, but regardless, they are quite busy clinicians. So despite being the main referrer, they can sometimes overlook certain allied health and different referral pathways, especially to exercise physiologists. As unfortunately, like we've kind of talked about throughout these presentations, exercise can still have a bit of a stigma behind it when working with cancer patients. And even some oncologists still hold the view that cancer patients shouldn't exercise, which that opinion is starting to change as there's more research out there and a lot more awareness. But we do need to be aware that sometimes we won't be referred to, but not because we're not important. So the next team member is the GP. So a cancer patient's GP will still have the same role as what they would do in any other cohort. And this GP will be the key referrer after the oncologist. So you may get more referrals from a GP than what you will the oncologist directly. And they're the main people that will then contact back about regarding comorbidities, anything like that, blood tests. They're often a little bit easier to get in contact rather than the oncologist. Next is a physiotherapist. So physios can wear many hats in the cancer space, particularly passive management post-surgery, whether that's a musculoskeletal injury or a cancer-specific surgery. Regaining range of motion, like we talked about in the last presentation, scar management, other injury management. And they can also do further training to then become a lymphedema therapist. So these are the people that do the DEXA scan monitoring, lymphatic massage, so aid with that lymphatic drainage, and the garment fitting and management. So as a bit of an example, these are the garments. They will be fitted with a custom garment for that area of the body, and that can be any part of the body. So from neck to arms, legs, trunk, anything at all. And obviously, depending on the area, it can be quite a tricky thing to fit. Hence why they have specific garment fitting appointments to do so. So anyone who was experiencing any impact to the lymph nodes, like we talked about before, we definitely want to refer to a lymphedema therapist, especially if we can get it in before any lymph node involvement with treatment, so before radiotherapy. Dietitians. Dietitians are one of my favorite people to refer to in the cancer space, especially in terms of how to make sure they're maintaining muscle mass or gaining muscle mass. They work quite hand in hand with EP because we're trying to gain the muscle mass via exercise. But like I said before, they need the fuel to do so. Unfortunately, some patients they can almost find the weight loss initially a pretty positive thing, which is really, really concerning. I have worked with quite a few patients who have almost seen the sudden weight loss from chemo and other treatments as a positive thing, which it's really not. And sometimes by the time they realize themselves that it's not a positive thing, they're very far down the rabbit hole. So it's an area we need to make sure we support our patients in, but also referring to a dietitian. They just know how to talk about it in the right way to make sure that the patient is aware of how important maintaining their body mass and muscle mass is. That being said, some patients do also gain weight from different hormone therapies and chemotherapies as well. So sometimes a dietitian referral is quite helpful to help the patient lose weight down the track, but I never really talk about a goal of weight loss with cancer patients so much because, as we talked about with the sarcopenic and cachexia risk, you're way better off having a bit more mass on your body while you're going through all of those sort of treatments at the time. A dietitian referral is obviously important in those areas, but vital for any head and neck cancers, especially throat cancers, because head and neck cancers can then impact tongue function, salivary glands, swallowing, all of those areas, which then can really impact a patient's ability to eat. So dietitians can be quite helpful in suggesting softer foods and meal replacements that throat and neck cancer patients may be able to tolerate a little bit better. And like I said, a dietitian is always going to be helpful even post-treatment for a cancer patient. So once they're finished with treatment, absolutely, if they haven't seen a dietitian before, I would highly, highly, highly recommend that we refer to them. A psychologist. Now, no surprise there. There is a huge amount of emotional distress and burden that comes along with a cancer diagnosis. And another allied health professional that I would refer any cancer patient to in a heartbeat. So we're all aware that cancer is not a nice diagnosis to have, but there are often a lot of issues with dealing with the treatments while they're going through them, but also after treatment. So quite a few patients I've worked with have reported that they've found it quite difficult once they have stopped with all of the appointments. They've kind of made it to the other side and they've really started to struggle to know what their identity is now and how to move forward with life and the fear of relapse as well. So a psychology referral is very, very helpful. And as we all know, can sometimes have a bit of a stigma attached to it. So gently having that conversation with people and even just drip feeding it here and there. If they've never seen a psychologist and they're not particularly open to it, just purely letting them know that that support is there if they do wish to take it. And a speech pathologist. So especially for the throat and neck cancers again, prior to working in the cancer space, I hadn't really afforded speech pathologists as much recognition as what they should. So they don't only help with speech, they actually have quite a big role in helping people improve their eating and drinking capacity, speaking, yes, breathing and swallowing. So those 5 main areas that are really tricky for any patients with a head and neck cancer. And obviously very important areas for everyday living. And finally, where do we, the EPs, fit amongst this team? The top one I'd say is exercise education. So like I've been mentioning the whole way throughout these presentations is we want to remove those unhelpful exercise beliefs in the cancer populations. Make sure that people understand they're safe to exercise, they're encouraged to exercise, and of the huge benefits it can hold. we provide that exercise delivery in terms of rehab, which can be, in conjunction to everything that's going on cancer-wise, but these people will still be experiencing comorbidities, injuries, etc. But also helping them achieve that exercise medicine dosage, which, like I said, can be extremely overwhelming to start with. And we've got the expertise to be able to make that exercise specific, safe, and monitored for these patients. We also support their psychological state quite a bit. Don't get your role confused with a psychologist, because it can feel a little bit that way. You may see someone once or twice a week, which is more than what their psychologist, their GP, their oncologist will see them. But making sure that they understand the benefits of exercise, helping them feel heard, and simply just, you will have difficult conversations if you do see any cancer patients. But just acknowledging the difficulty of what they're going through is often all we have to do as EPs, and it can have a huge benefit in how they feel. Next, we're also going to aid in referring to the necessary clinicians as needed. So oncologists and GPs can be very busy people, and wearing many hats when they're thinking about who needs to be on the treatment team for a cancer patient. And that's where we can play quite a role in highlighting any red flags of who we need to refer to, and making sure that the cancer patient has the best outcome possible. Next point, back on the re-education of the exercise side of things, making sure that patients and their families understand the benefit of exercise and why it's necessary. And finally, the comorbidity management. So a person dealing with cancer will also have a multitude of other potential health risks that exercise can also help to manage. Now, those are just a few areas that will play a role in, but all very, very relevant to us, and things that we'll want to consider throughout our management of anyone dealing with a cancer diagnosis. Alrighty, so that's the main treatment team that you would typically see for a cancer patient. Obviously, like I said, every team will vary a little bit. But we've got one more video to go where we'll just go through some case studies. So have a bit of a stretch and a break, and I'll see you in the next one.